And my name is Alan Higgins. I'm the Health Equity Network lead. Alison, introduce yourself again, given that some people have joined since you last spoke.
Hi, everyone. I'm Alison. I'm the Health Equity Network coordinator. I'm just back from leave, so if you sent me a message over the past couple of weeks and I haven't gotten back to you, I shall today.
And if you're all wondering, Alison's been in New Zealand and Australia, and I'm very jealous. If you haven't been on the Health Equity Network webinars before, then you've already picked up probably that we do run these webinars every month, and we keep them pretty informal, as informal as you can have with a webinar anyway. And the webinars are generally on themes that are suggested by network members, and this month is a special one, which we do once a year, where we invite people from the network to make presentations about their work. And because of the timing and the way that we want to keep time for people to ask questions, make comments, we restrict it to 3 presentations of around 10 minutes each. So we had 7 people put forward suggestions, and unfortunately we can't have everybody. So the 3 that we have selected hopefully are nicely contrasting as well in what they're going to be talking about. So in a moment, we're going to start off with Lisa Westhorpe, who will be speaking from Sport for Confidence, particularly talking about work to enable better engagement with sports and physical activity. And then we'll have Helen James from Nutrieri speaking about the development of the Nutrieri project, but also about how that augments existing services, again, to enable people to engage with weight loss and looking at health equity issues there as well. You can correct me in a minute, Helen, then, and get it right. And then we'll have Debbie Nolan, who is from Citizens Advice in Liverpool, talking about providing services to reduce poverty, particularly associated with primary healthcare. And whereas usually we'd run the presentations and then open up for discussion, this time, because the presentations are different, what we'll do is have a 10-minute presentation, open up for questions, and then move on to the next presentation. And then open it up at the end for more questions. We will definitely finish by 1:30, as we know this is people's lunch times, and you're all busy as well, and you'll need to get back to work. And as Alison said at the outset, if you can keep your cameras on, that would be great, so we can see everybody and you can flag up if you need to speak. Otherwise, use the raise hand facility on Teams. But if you can stay on mute as well, that will cut out the background noise. So we'll go in a moment to Lisa, and as was apparent there, if you need to correct anything in the way that I introduced you, then just do so, and no problem with that. So first of all, over to Lisa.
Thank you so much, Alan, and thank you for the great introduction. Now I'm going to try and get the tech bit right and share my screen, so just bear with me for a second. Okay. Let's see. Let's do a slideshow for everybody. Hopefully you can see that. So perfect. Fantastic, thank you. So my talk today is going to be on allied health professionals and reducing health inequalities through physical activity, and we're using Sport for Confidence community interest company as a bit of a model for that. So I'm Lisa Westhorpe. I'm an occupational therapist and system partner lead at Sport for Confidence. From that title, you probably can't work out what I do. So as an occupational therapist, I'm supporting people to do the things they want or need to do, their meaningful activities, their meaningful occupations. And the system partner lead bit talks a little bit to the national work that we do, as well as the local work down in Essex. So Sport for Confidence, we are looking to reduce health inequalities. And a lot of our work is around doing that through placing occupational therapists, so those allied health professionals and sports coaches, into leisure centres. So as occupational therapists, usually we're working in more of a healthcare setting, possibly social care, but this is a bit of an innovative approach and taking those occupational therapists from health and placing them with sports coaches into leisure centres. And we do that to promote access to and participation in physical activity, mostly for populations who are experiencing barriers to participation. So we want to reduce those barriers and make sure that we're reducing health inequalities and reducing physical inactivity as well. So usually I like to start by just saying why we're doing what we're doing. Why is it a problem? You know, why is there an issue here? And unfortunately, physical inactivity is a big public health concern. Most people aren't meeting those recommendations around physical activity, and particularly in marginalised populations. And that's a real issue. We do have occupational therapists who are working with people within sport and physical activity sector, but it's not really established yet as kind of within the UK public health and physical activity sector. And I just put the Royal Society of Public Health report as a reminder to myself on there, because this report has recently been published and really speaks to kind of unlocking that potential of the wider public health workforce. So definitely check that out. I think that they're definitely highlighting the fact that allied health professionals can be part of this workforce and are already to some extent, even if they don't have public health in their job role, in their job title. So let me just click forwards. My computer's just thinking about it for a minute. There we go, that's better. So unfortunately, there are a lot of things that play into physical inactivity. And as occupational therapists, we're well placed to address physical and mental health, as we're dual trained in both aspects. We're trained to look at the person, the environment, and their occupation. And we're talking about occupation here as in what occupies you, not your job. So those activities of daily living that you want or need to do. So this is a bit of a depressing slide. What can we actually do around making sure that people aren't physically inactive? So as occupational therapists, we can really support people to access physical activity by looking at what's important to that person. So part of what doesn't work, we've found in physical activity, is that kind of one size fits all approach, and maybe prescribing exercises that aren't linked to what people want or need to do. I've definitely had that experience as a patient myself. It's not always easy to fit extra things into your day. How can we make it so that people can be physically active as part of what they're doing anyway? We look at their roles, responsibilities, habits and routines, their organisational skills, and we provide that link between the sport and leisure industry and health services, so we can kind of sit between and coordinate that. So I'll just tell you a quick bit about Sport for Confidence. So we are an occupational therapy-led service. We're reducing health inequalities and supporting people to overcome barriers to participation. And how we do that is through improving access to physical activity. So mostly that will be our work within leisure centres, again, occupational therapists and sports coaches working together. We also have primary care and long COVID services as well. And a lot of that is around supporting access to healthcare services for marginalised populations. So things like learning disability health checks, people who don't normally access their GP services, trying to get them to have that equity of service. And we also work on a national level. So my system partner lead role is funded through Sport England. So we became a Sport England system partner in 2022, and that provides us some funding to share the work that we're doing locally in the South East on a more national level. And I've just included that graph at the bottom just to reiterate really that we're not taking people who are really quite active already and making them more active. It's more looking at people who are really at risk of health issues due to sedentary behaviours, and supporting people who are physically inactive to do any level of physical activity. And my computer's having a think about it again. There we go. So I could spend all day talking to you about Sport for Confidence, but I think it's probably better that I show you what we do. So I'm just going to find a quick video, which I think is going to give you a real sense of what we do as an organisation.
Sport for Confidence is a community interest company that places occupational therapists together with sports coaches to create opportunities for people through sport and physical activity. Occupational therapists are the experts in that activity and health link, so we're really concerned with what matters to the individual and how we can support them to engage in activity life which are meaningful for them.
At Sport for Confidence, we promote health and well-being through sport and physical activity. We take an holistic approach when working with our clients by considering all of their needs. For example, the physical, the psychological, the social and the environmental, in order to help remove any barriers that they may face to participating in sport and physical activity.
Sport and physical activity isn't always as accessible for some people as it is for others, and people face barriers to participation. So in our groups, we work with people with long-term health conditions, disabled people, people with autism, learning disabilities. Our role as OTs is to really make sure that people have the best experience and that we make those adjustments and we deliver the activity in a way that everybody can enjoy it and benefit from.
Within Sports for Confidence, we deliver our service to a variety of means, such as a virtual service. We do group indoor and outdoor sessions, as well as phone consultations and one-to-one sessions.
We offer a wide range of activities ranging from dance, soccer, athletics, cycling and boccia. This also means that each activity is focusing on different aspects such as strength, balance, coordination, finding and gross motor skills.
I'm not going to play the whole of that video because it does go on for 5 minutes, and I'm aware that I don't want to take up everybody else's time as well as my own presentation time. So I'm going to go back to my slides. Just bear with me a second. There we go. Okay, so from the video, you could see a little bit about what occupational therapists offer within a leisure centre and how we promote health through focusing on what's important in people's everyday lives. So this slide really demonstrates some of the skills that an occupational therapist might be working on, how we can use sport or physical activity as a tool to help people reach their goals. So it might be that you see from the flyer that somebody might be going along to a dance session, but actually the occupational therapist would be working on, for example, memory skills, coordination, sequencing the dance moves during that time as well. So there are many different things that the OT might be working on to support that person to meet their goals. So I think this really kind of highlights an issue as well around where we deliver services more broadly. So, you know, is there a reason other than because we always have that we take healthcare services and we deliver them in hospitals, for example, you know, outpatient rehab? Could it be that we reimagine that, and could those services be delivered in a leisure centre so that once people have been discharged from that service, they can continue to access the service of the leisure centre? You can't ever really be discharged from a leisure centre, I suppose is what I'm trying to say there, and people can carry on using that once they've finished their course of treatment. So again, this slide just speaks to a little bit of the strengths of OTs being placed in leisure centres. So forming that link between sport and leisure industry and health and social care, providing mentoring and training to leisure centre staff towards being more inclusive so that people can really access the opportunities that are available to them. And also thinking about it from an equality perspective, you know, we want to encourage people from marginalised groups to take part in physical activity. So there's a social justice aspect to this a little bit as well. And to use occupational therapy terminology, an occupational justice issue in terms of people not being able to access the activities that are meaningful to them. This is my final slide, and it just really kind of highlights some of the benefits of the Sport for Confidence model. We're really placing the participant at the centre of our model, centering their voice and providing those links. So the diagram shows some of the other sectors and organisations that we might link in with. Also, I kind of wanted to highlight that sense of belonging and community as well. So this isn't just about checking a box to say, yes, I'm physically active 3 times a week. this is people feeling that sense of belonging within their community, and they come along because it's fun, not because they're trying to do their 3 times, 30 minutes a week of physical activity. So ultimately, we're wanting to support those in our communities who are furthest away from physical activity and sport to be involved and to participate. I think that probably takes me to the end of my presentation, and I don't want to take up everyone else's slots as well. I'm sure I could speak all day about this, so please let me know if you have any questions.
That was excellent. Great stuff. Thanks very much, Lisa. I've learned such a lot from that, and great to see that focus on the people who are furthest away from the physical activity targets, I suppose. There's a question from Eamon in the chat, and if you could have a look at that. But Eamon, would you like to come on screen and ask the question, or would you rather just leave it in the...
Hi, no, I'm happy to come on screen. Can you hear me okay?
Yeah.
Yeah. Hi. Thanks, Lisa. That's really interesting, that work you're doing. I've got a more narrower focus in terms of equity of access. There's some people with sight loss who also may have other disabilities as well. And we are doing some work with leisure centres and working with an organisation called British Blind Sport on that specific aspect of it's from start to end using the equipment, but it's about the whole welcoming process. Do they take guide dogs? All of those questions which make someone's experience, good. Have you come across any sort of solutions to this that would help?
I think there are a few things that we found that really help to support people to access from a variety of different kind of disability perspectives. One thing that we found in increasing people's confidence is doing things like either an audio or video tour, so that people know in advance where they're going to and what that kind of leisure centre looks like. Just to support people to feel confident in being able to access that space, because I know myself, having moved house reasonably recently and then wanted to go to my local leisure centre, it is a little bit intimidating to go into a space that you don't know. And this is somebody, I'm somebody who does physical activity quite a lot anyway, but if I didn't have that background and it was a completely new space to me, how would I feel going into that space? And I think to be able to offer people things to support them to feel confident in that kind of the first time they access, because that is where we think we can really support people. It is increasing that confidence and just making them feel comfortable and like they belong. Yeah.
Do you do any kind of awareness training with staff? I suppose you do, don't you? As part of
yes.
We've done some of it, but there's so many leisure centres, and there's we want to tackle it at a system level in a way, so that there's a requirement of all leisure centres to have an accessibility audit across a whole number of different sort of thresholds to make sure that they're not inclusive to one particular person, but then not to another. But it's difficult to do, and I know, and there's the costs and stuff, and they're all struggling with finances because a lot of them are commissioned by local councils, aren't they? So yeah, it's a big thing. But it's really interesting to hear what you do.
You're absolutely right, and I think that is a really important point. That with it being that people don't necessarily have the money for training, but if we flip that round and say, well, actually, you're missing a whole section of the population here who could be accessing your services and paying to do so, using your cafe, all the different things that they could be doing within that leisure centre. So to some extent, we do provide training and mentoring for leisure centre staff. And we're working specifically with Everyone Active at the moment, who have leisure centres down in the southeast and other areas of the country as well. But I think there is a real need there to use spaces better and to really kind of make sure that those businesses are aware of the business opportunity as well as being inclusive. Yeah.
Thanks very much, Eamon. That great question. Danny, go ahead.
Yeah, cheers. Sorry, I didn't know if we were asking questions now or at the end.
Yeah.
But just a really quick one for Lisa. Really great presentation. I've met with your colleague Jake before, so I kind of know about the model, and really supportive of these clinical roles that are supporting people to be more active, especially those that are facing more inequality. And there's some really good, there was a really good pilot that's been in Liverpool recently around clinical exercise physiologists, and some of the outcomes that came out of that were absolutely fantastic. I think my question for you is around that Sport England system partner role and supporting kind of like other organisations to hear about it and adopt it, because obviously your organisation is just like in a corner of England.
Yes.
I'm just kind of interested how you've supported other areas to adopt this model.
That's a really good question. That's something that we're looking into at the moment. So we are just based down in the southeast. We do have some members of our kind of national team. So I'm actually based in the northeast. And we cover the country in terms of being able to offer lectures and student placements, which has been quite a nice way for us to expand our reach. There's always going to be students who need, you know, practice placements for occupational therapy, and that helps us to move into different areas of the country that wouldn't necessarily be down in the southeast. So, for example, I was recently supporting a student at Teesside University, and they're in Darlington. So that's really helped us to look more broadly and to be able to offer a service within other areas where we're not geographically based. So I think that's probably the best example I can give. It's a kind of partnership working as well with other organisations in that system partnership as well with Sport England.
Yeah, sounds good. Thanks, Lisa. I might drop you an email about that.
Please do. Yeah, that'd be great.
Excellent. Thanks, Lisa. That was great. Thank you very much.
Thank
and
you.
We can come back to that again after the other presentations too. So if you have questions, please do log them in the chat as well. So thank you very much, Lisa. Helen, next up. And I realized when I looked at your introduction in the chat, I more or less said the opposite of what it is that you do. So apologies for that. I love the comment scales of her fish as well. So please go ahead and please introduce yourself again.
Oh, okay, thank you, Alan, and it's absolutely fine. It actually is really serendipitous that you did, because we predict that people do assume a lot because of, you know, what we're up against and challenging in some ways. So I will start by sharing my screen, and then I can relax a bit into presenting. Might have to get the right screen up. There we go. Can you see that okay?
Yep, that's all good.
Thank you. Yeah, so I'm Helen. I'm currently sat down in Devon, but Nutrui sort of like reaches nationally, internationally in some cases. But we're very sort of like early in traction and progress, even though we're now in our 9th year of participatory research. So in 2015, we started listening to workforce, citizens, communities, to sort of try and figure out how weight management services just aren't working, and also I was a long time valued customer of many slimming clubs, having successfully shifted many stones many times, never learning actually healthy behaviours around food, and never really finding a way to stay where I got to ever, each time increasing my weight by more. It's a common true story for a lot of people. So we're all about how do we rebuild trust in a system that is doing great work and is there to support people's health, and to sort of like demonstrate how making it about weight change is getting in everybody's way. It's leading to less cancer screening and all sorts. So it's a real perhaps the most intersectional characteristic of citizens to go in the way across all the health groups and the protected characteristics out there. So yeah, thank you for having us along. I'm going to play a short video, about 4 minutes, and then carry on.
Not sure the sound is coming through yet.
Okay. Bear with me. That'll be when I click share, I should include the sounds. Oh, blimey. Okay, excuse me. We'll go to the beginning of the slide again, and then so you can see the screen.
Yeah.
Super. Since 2015, we've been hearing from people about their experiences of weight talk and how this affects them. We've also been listening to those who work in health management and promotion
to discover how their work feels. We've examined 3 decades of policy and strategy designed to improve population health. And we've looked into spending focused on weight change and its impact on health outcomes. In May 2022, we took some of this data to the House of Commons, where Jeremy Hunt asked us about weight discrimination in healthcare. Everything we do is informed by the lived and living experiences of people, especially the 300 or so that took the time to comment here. Pursuing and monitoring weight change is not having the positive effect on population health that we previously thought it did. So a group of volunteers got together and talked about what needed to change. We discussed the research and evidence that already exists to inform the design of our first Food and Body Ease courses. And some of us went on to test and learn with the course, facilitating one-to-one coaching or in small groups. We used Happiness Pulse to measure our impact, a measure of social and emotional health that incorporates ONS4 and the short Warwick-Edinburgh Wellbeing Scale. And we partnered with accessible Pilates group Mobilates to measure increases in activity over 6 weeks. And this is what we heard afterwards. Robust research over 14 years with over 11,000 participants shows us that it is the beneficial behaviours that we sustain over time that bring health, and not changing BMI, which is also rarely sustainable in itself. The impact of Weight Talk in the consultation room and beyond. A paper by Shaw and Meadows in 2022 states that weight stigma among healthcare providers is linked to healthcare avoidance in patients, including underutilisation of preventative healthcare and screening. Evidence consistently demonstrates that stigma is more likely to lead to increased allostatic load, higher prevalence of chronic diseases, and further weight gain, independent of BMI. Meanwhile, healthcare systems are still focused on weight change for health improvement, and referrals are being made to weekly in-person and digital slimming clubs. Questioning individual willpower, success or failure, rather than questioning the out-of-reach and unsustainable weight classifications. So we drew on the lived experiences of the evidence base again to co-create the weight neutral training course for social prescribers with formats for time-poor clinicians and the wider food and movement professional workforce, testing and learning as we go. In time, we hope to move a largely weight normative system approach towards a weight neutral inclusive route to improved population health and poor health prevention. The co-production continues with every cohort of weight neutral training and Food and Body Ease participants that come through our door. So we drew on the
Okay, so a little bit of an update. Recently, a local GP trainer who also has a special interest in women's health and medical education has been taking a look at our full training course, our full weight neutral training course, and worked one-to-one with her to deliver that onwards to 12 GP colleagues. And the early feedback is that they were very interested in shifting the focus away from weight to health, and we're keen to learn more about what we're doing, which is great news. And so I often get into conversations, as you can imagine, in passing when people ask, what I do. And a really recent conversation I had, people often feel I must just have one of those faces that people feel that they can really share anything with me, and I like that because I'm really transparent and open in return. And so this lady, she shared that her mother felt a lot of shame around her size, and sadly she passed away at the age 67 from a lung condition as a non-smoker, but she was just terrified of going to the GP because her weight would be made culpable for her health problems that she experienced over a number of years. And then she also shared another story about her grandson, who was measured by the NCMP programme, had a letter home to say that he was overweight. And then she got a picture out and showed me a picture of her grandson. And I was just flabbergasted because this child was a child with no visible weight, excess. And then it might shock you to learn that the person that was speaking to me was a nurse practitioner. And so I told her what we do, and she's really keen to talk to her superiors to get us in and talk a bit more about it, because what we do can really augment other people's services, because 90%, 95 or even 99% of the work happening out there for health promotion is fantastic work, and measuring weight is getting in all of our way and creating a whole heap of unseen health inequities. So this is our future hope to see a Nutrui community social prescribing hub wherever you find a slimming club. And we hope to do that with a business model that taps into the billions spent on diet culture rather than relying on commissioning. So I'm a Core 20+5 ambassador. We host a place over on Future NHS if you want to come and talk more about working weight neutrally. And yeah, feel free to ask me anything. But we get it, don't worry about using old language or labels, and you can use this QR code if you want to literally send a comment in anonymously. Yeah, thank you very much for listening.
Excellent. Thanks so much, Helen. That was really interesting, and I'm conscious that you've been on the network from very early on and contributing a lot, and I'm afraid I only now understand what it is that Nutrui do, and I wish I'd watched that video earlier. That was really interesting. Really interesting as well the way that over the course of this development you've used published literature, but you're also drawing upon volunteers' views, and it's so essential to balance the published literature with the views of people who are experiencing the issue as well, and dealing with one of the key public health issues that is facing the country. Excellent. Thank you very much for that presentation. Are there any questions that anyone would like to pick up at the moment? Or any points anyone would like to make? And if there aren't just yet, then you can log questions in the chat and we'll come back. Oh, Matthew, please go ahead.
More of a comment than a question. And I've heard Helen talk about Nutrui a number of times before, and I think we're very much aligned as an organisation. Our organisation, Health Equalities Group, who run the Food Active programme, very much aligned with the thinking around addressing weight stigma and taking more of a sensitive and health-based approach to this issue. I think a lot of the comments that Helen makes about some of the problems associated with weight management services, and I think we can probably throw the new pharmacological interventions into that as well, are holding back a lot of the potential good that can be done in terms of addressing healthier weight. It's probably not a term that Helen would use. But I think the other point I wanted to make was just the importance of perhaps taking a bit more of an upstream approach as well, and some of the social determinants of weight, and in fact the commercial determinants in particular associated with weight or unhealthy behaviours, and perhaps that's something that our new administration, if and when they are formed in July at some point, are going to take a little more seriously. But a lot of work that was meant to take place over the last 5 years around addressing junk food advertising, around planning for health, using planning levers to address health, an awful lot of work which has not actually come to fruition, but taking that upstream approach, combating some of the social and wider determinants of healthier weight is something that really needs to kind of get crystallized and some movement on, rather than lip service. So it was just kind of another reflection in terms of those more upstream preventative approaches. Downstream work generally extremely costly, only really benefits a very few number of people, but it's almost as though it's kind of ingrained as the way in which you kind of deal with less healthy behaviors. So just a few comments from my side.
Thank you, Matthew. Yeah, if I could just sort of like speak back briefly to those. There is great work going on reducing stigma, and it's about, I think our work is more about letting general population know that, because if you look at nearly 2/3 of high weight people delay or withhold to some extent engaging, and it's not an either or sort of thing. It's like, and we're certainly not asking people to stop pursuing intentional weight change. We're just about improving access, and that's across long-term condition groups, you know, the co-occurring health needs that they're withholding with. You know, we think we have something that can be easily measured to show improvement and better health outcomes across all the major conditions. And we just need to stop monitoring weight to do it. We need to start measuring health and not weight. You know, it's almost too simple, you know, to sort of like be true. We like things to seem complex, and we think they'll stay complex for as long as we try to solve obesity, rather than looking past that and saying, actually, what do we want from people when we ask them to change weight? It's better health. So let's focus on the better health, because the best answer I've had so far is it's easy to measure BMI. And if we're just sticking with BMI because it's easy, you know, we've really got to start scratching our heads a bit more about this. And we can help do that, because it's not just about solving weight. And one way to bring equality to a system quite quickly is to have some SNOMED coding for weight neutral, brief intervention. So for a GP, rather than just having weight to talk about and to be incentivized with a payment talking about weight or making a referral, let's have a weight neutral one. It's really quite easy. And also developing pathways. So I'm currently supporting somebody who's post gastric sleeve surgery. You know, we have people on wait lists at tier 3 and tier 4 who the treatment doesn't cure their poor relationship with food and physical activity. So it's about creating those. Thank you.
Thank you, Helen. That's excellent response as well. And I'm going to move on to the next speaker. Thanks, Tara. I've noted that you want to ask a question. So that we don't feel that we're rushing, Debbie, we'll move on now. And then please, Tara, do come back after Debbie's presentation to ask the question again. So now Debbie and Claire Mahoney are going to talk about the Anti-Poverty Health Justice Partnership work in Liverpool. Please go ahead, Debbie.
Okay, I'm going to try and share this. Have I done so? Yep,
you have. Looks good.
Okay, great. So Claire and I are going to do a two-header on this. I'll start, and then Claire Mahoney will take over. So let me just see what I'm doing. Okay, so I'm going to talk to you today about Citizens Advice on Prescription Liverpool, which is a blended social welfare and wellbeing support offer for frontline health professionals in Liverpool. We established this programme in 2015. It was very much designed in response to Liverpool's significant economic disadvantage and stubborn health inequalities. And essentially, it's a rapid response service to support frontline health staff and dedicated community partners whose patients are impacted by the wider determinants of health. It has two linked but distinct parts. So it has a traditional, what most of us would think of as an anti-poverty, a traditional citizens advice offer, welfare benefits tribunal, PrEP representation, debt management, food and fuel support, etc. And then linked to it, but for secondary care referrers only, we promote and support access to community activities and services, two of which have been mentioned today, but for patients with priority health conditions, and I'll talk more to that shortly. Okay, so what began essentially as a service for primary care has since developed to include secondary care. So just to reiterate, every GP team in Liverpool has access to a SWIFT anti-poverty offer. They may have their own, and often do, in the majority do have their own dedicated link workers or social prescribers, but in Liverpool, Citizens Advice on Prescription provides every GP team with this swift response anti-poverty offer. Our priority health conditions that we target are mental health, cancer, respiratory conditions, women on the perinatal pathway, and called +20, people living with social and economic disadvantage and isolation. Over the last 3 years, we've begun to pilot an additional service to the one that we originally designed, and this was to focus on women on the, or families on the perinatal pathway. And since we've begun to focus on this particular cohort, we've been able to support over 2,000 families, and we now have evidence of the effectiveness of the in modifying risk factors related to child poverty and maternal mental distress. So the referrals come from, there's no self-referral. So this is not Citizens Advice services in a GP centre. This is Citizens Advice services for GPs who assess their patients as being vulnerable to the wider determinants of health. So who can refer? Primary care teams, integrated care teams, MDT, secondary care, Liverpool Women's Hospital, pulmonary rehab. I won't go through them. The Nest Clinic is the non-English speaking team based at Liverpool Women's Hospital. We have cancer services, the cancer nurse specialist based on wards. We cover long COVID clinics, and we have a cohort of what we call trusted partners, and they are organisations that are essentially voluntary sector organisations, but whose staff act as proxy frontline health staff because they're closer to the community and they understand the needs of their service users, and referrals are often two-way. We receive and process over 14,000 referrals a year. We will secure through various activities approximately £10 million a year, and this is essentially going into the lowest income households in the city. We help manage an average of 3 million debt a year and provide access to charitable support such as food banks, food pantries, providing access to fuel vouchers, household support fund awards, etc. And this will come to no surprise to any of you working with the public across the country. Increasing numbers of people are presenting with housing related problems, and that's because essentially we have a housing crisis in the country. Unusually, this service has lots of agreements, service level agreements and data sharing agreements, and what we've been able to do since its outset is link all the person level data that we collect within Citizens Advice, and we are able to share that data with the local Descro, and that this data is then linked to social care, primary care, secondary care, mental health services and local authority adult services, and then it's scrutinised by a health equity team in Liverpool University, and they look for, well, they've been working very closely with us for the last at least 9 years, but specifically the last 6. I'll touch upon some of the research findings, but I want to make time for Claire to go into much more detail about this. So I'm just going to go through this. If anyone has any questions, then of course they can ask after Claire has spoken. So what we do know is that the service we provide has had an impact on a large number of people between 2018 and 22, and even before that. So 58,000 referrals. We've supported more than 25,000 households, reaching 65,000 people, and interestingly, over 16,500 of them have been children. The people that we see have high levels of health need compared to the rest of the Liverpool population, with 60% having multiple morbidities, 70% living in poverty, and 1 in 3 adults are diagnosed with depression. 1 in 6 have problems with substance misuse, and 40% of them have at least one mental health problem. Contacts with mental health services are 3 times higher than the average Liverpool household. A&E attendance is 30% higher. Emergency admissions 50% higher, learning disabilities, autism, double the Liverpool average, 1 in 3 complex families. What you'll see from this is that we're reaching, by working with frontline health staff who are able to assess the needs and circumstances of their service users, we are reaching into the most disadvantaged, disproportionately disadvantaged households in the city. We've been doing this work for nearly 10 years now, more if we include the pilots that we touched upon, that we worked on to develop this work. And if we accept that a health justice, the definition of a health justice partnership is a collaboration between health services and organisations specialising in welfare support, then we think, the first health justice partnership in Liverpool. I'm going to hand over to Claire now, and hopefully you'll find what she's saying really interesting. I know I do. Thanks very much. Claire, I'm going to control this for you, if that's okay.
Yeah, that would be great. But I don't really have anything to add for that. I mean, Debbie's I think summarised perfectly well what the kind of headlines are in terms of what we're finding. I mean, no, just go, if you wouldn't mind go back to the first slide, Debbie, about the research. So the only thing that I can add is just to say that, you know, this is a big service. It is part of the social prescribing family, but it is social prescribing, the money that comes down from NHS England, is generally speaking for social prescribing link workers and health coaches. This is for a social welfare service. That's largely what we commission, but we commission it so that it is fully integrated into a wider social prescribing and wellbeing service. That's the aim anyway. And there is good evidence that in lots of places it is very well integrated. Social prescribing link workers, generally, they refer often into social welfare services. So that's an extra step, I suppose, because Liverpool is the 3rd poorest local authority in the country. We've put the social welfare bit before that so that health professionals can refer directly into a social welfare service. And actually the conversion rates from social welfare to wellbeing link work in some parts of the city, based on the data that we've got, around about 1 to 2. So 2 to 1. So for every 2 referrals, there's 1 conversion into wellbeing link work. And there is probably something about just working with people where they are. You know, if you're worried about whether or not you can pay the bills or you've got money coming in, you're unlikely to have a lot of headspace for for some of the very rich wellbeing offer, but it might be difficult to prioritize that, and other speakers have talked about that today. The next slide I will talk about, because it's got the latest figures. So there's actually the numbers of referrals between the time frame with 30,500 people were referred into the service, and that generated 70,000 cases. We estimate that about that impacted on 80,000 people, because of course people live in households and the service is for people in households, and that again, that's an estimate of the number of children. I mean, Debbie's already mentioned this, but what I would flag up is what we know about the service in terms of reaching people with higher levels of complexity than you know, other services. So one of the, I suppose, the inverse care, we know the inverse care law applies, that the people, you know, I don't know if people are familiar with that term, but it used to be talked about a lot more probably than it is, because now we have the language of health inequalities. But yeah, it's an idea, a concept, which I think is well borne out by the literature, that people who need services most have the most difficult access to them. And I think that is particularly true for preventative services. So we know that people do use a lot of services, but a lot of the people that we're most concerned about are less likely to use preventative services because they have lower levels of trust, and their lives are more difficult, so they have they're much less able to make the space that they need engage in preventative support. So this service has been exceptional in terms of reaching people with very complex needs and higher levels, as you can see from this, higher levels of mental distress, mental illness than others. I'm just going to skip down a couple of slides, Deb, if you go to, so after intervention, that's the one. So in terms of impact on healthcare utilisation, because we've had this access to this linked data, so this is a good hierarchy in terms of the hierarchy of evidence. It's strong evidence. It's a reduction in antidepressant prescribing. 100%. It's probably an increase, a decrease by 50%. So that's a very that's a good outcome, and one that Big Pharma would be very pleased about. And then 7 fewer A&E attendants per 100 clients for mental health distress, and there's also the decrease in emergency admissions, as Debbie said. And the next one, the next slide, is that so we're using standardized tools for this. Again, you can see good reduction in anxiety, depression, and that the benefits seem to be greater for those who are among the poorest, and also probably with higher levels of mental health need. So referrals, those referred from secondary and specialist services, people with SMI generally, their anxiety and depression is reduced by 52% using this standardized tool. Or that's the EQ5D is not it's a health outcomes tool, not a mental health outcomes tool, but it does include, it has got that dimension within it. If people are interested, the link is there. So that's that's just a very brief introduction to some of the impacts for the health outcomes. Our staff love it, and they talk a lot about how it makes their job easier, and there's something really important about the relationship with services as well.
Excellent. That is such a good presentation and such a great service. Thank you very much, Claire and Debbie. There are questions in the chat and the Q&A, if you click on that as well, and there's questions for you in there as well, Lisa and Helen as well, if you wouldn't mind addressing those, if you can, because we're running out of time, and I did promise to people that we would come back to questions. But that's an excellent service. I work in Cheshire Merseyside 2 days a week, and I wasn't aware of the work that was being done there. I would love to follow that up with you afterwards as well. Can I go back to Paul, who posted a question earlier on? Go ahead, Paul, and you come off mute. There you go.
Yeah. The evidence is, I question whether leisure centres are the right venues, because the evidence is that people who are on low incomes tend not to travel out there out of their neighbourhood to take part in physical activity. And I think from the speaker we've just heard about, I think they probably agree with that. People on low incomes, for lots of reasons, tend not to go to leisure centres. So I just wondered whether you got any thoughts on that.
Yeah, I completely agree. Yeah, I do agree on that, Paul. I think you're right. And we have experienced, as a community interest company, the issue around transport and travel to leisure centres, and having to advocate for clients to be able to get to where they need to be. but we have done more targeted work as well, thinking about some of those really marginalised populations who don't have the ability to travel. So, for example, we've worked with asylum seekers and got specific pots of funding to be able to work with those specific groups in their community. So some of our work is more outreach based. It depends on the needs of that community, and that's something that we look at in terms of the demographics, who's in our communities, who aren't accessing our services, and trying to really work on supporting those populations to be able to access through whatever that looks like. So most of our work is in leisure centres, but we do pockets of work outside of that, and I think that's really important. It's a really good point.
Thanks very much, Lisa. I'm going to go quickly now to Tara for the last question.
Oh, I just suddenly remembered it was pre-election period, so I probably I won't comment on what I was going to suggest. I'll wait until we're after the elections, but I'll contact Helen afterwards.
Excellent point. And well, thank you very much. And because we are at time, I won't go to some of the other questions, but I would suggest that everybody looks at what's in the Q&A and the chat. And I understand from this that you can actually keep responding to that even after we've finished the webinar. I'm going to make the assumption, one person, Anne Claire, asked if the slides will be shared after the meeting. I'm going to assume that we can do that, and we'll make that arrangement with the speakers to make that accessible on the network. And as we said earlier, the webinar has been recorded and will be on the network once Alison has edited it. Thank you very much to all three speakers. That was excellent, and we could easily go on for much longer and take more questions on it. But those were excellent presentations, and really good to see those connections being made across the network. And it's at this point where I usually announce what the next webinar will be at the end of June. We're rethinking that slightly, partly because what I'd like to do is make it something to do with the election. But of course, it's a sensitive issue, as Tara has pointed out, so we'll get our heads around how we make that possible. But in the meantime, it'll be on the last Thursday of the month, whatever that date is. Please do join us again. Thank you very much for joining today, and particularly to the 5 speakers. It was excellent. Thank you. See you next time.